what are your thoughts on invasive disease-free survival as an endpoint? Limitations is kind of unique in this space. It was kind of an impromptu question, but how does that endpoint compare to more common endpoints, disease-free survival, just as a standalone, progression-free survival, those kind of endpoints?
Yeah.
What do you make of it?
Actually, overall survival, of course, is our gold standard. So we need to get some overall survival data, both from the neoadjuvant pertuzumab as well as the adjuvant setting here. So that's certainly the goal. I think as a second endpoint, though, I actually like invasive disease-free survival because I think cutting out those non-invasive recurrences is very important. Of course, worst case scenario, as you mentioned at the onset, is distant recurrence and metastatic disease. Very important as well. But I think invasive disease-free survival is an appropriate outcome to be using for these trials, personally.
It does seem to get to the heart of what we're trying to achieve. It seems like it's a metric that really helps show, are we really achieving that potential for cure? Are we driving down that risk of relapse and meaningful relapse down as low as possible, which continues to be the goal?
Sure.
You alluded to it earlier, and so we'll go into this molecule, and that's trastuzumab emtansine, or TDM1. We saw a few years ago from the Catherine trial that if we incorporated TDM1 in patients with residual disease after neoadjuvant treatment compared to trastuzumab, we saw also invasive disease-free survival at 3 years drop from 88.3% down to 77%. So mathematically, a bigger gap there than what we saw with pertuzumab. Thoughts, and it sounds like I kind of already know where you're headed with that, but thoughts on how to incorporate this this treatment into or where you'd recommend it for breast cancer patients?
Yeah, I think of all the trials that have come out recently in the neoadjuvant and adjuvant space, the Catherine trial is, to me, the most convincing. As you mentioned, you've got about an 11% improvement in your invasive disease-free survival there, much better than the 1 to 3% that we just talked about. So in our books here at UK and I think across the country, this study is undeniably practice changing. It certainly has changed the way we practiced in a number of ways. One, in terms of just changing the molecule. So if a patient has residual disease, more than microscopic anyway, I think it's the standard at this point to change the patient's therapy to trastuzumab if they can tolerate it, rather than trastuzumab on its own. So that's certainly important. The other kind of factor that comes along is we do talk a little bit more, if we're on the fence, about neoadjuvant versus adjuvant therapy, leaning more towards giving that patient neoadjuvant, knowing we have this very important therapy that we can switch them to, and we need that prognostic information that comes about from their pathologic complete response or lack thereof. So huge trial, huge results. I think going forward, it's going to be interesting to see if we get similar results with some of the other antibody drug conjugates, namely trastuzumab deruxtecan, to see if this therapy has the same benefit. Is it any better than the trastuzumab emtansine? Where do we go from there? It's a very, very important piece of literature.
Yeah, and I think, and I want to follow up on adverse events here in just a second, but I think what this really helps crystallize is that value of actually having in vivo ability to manage or monitor response to treatment, and to be able to see in real time, is the patient having that, complete response we're looking for, or do we have a little additional ground? So that really helps. In addition to just having the new treatment option, it really helps solidify that going after that complete response and that neoadjuvant treatment, really getting those deep responses is really valuable and a key part of early breast cancer management. I think that's going to be critical when we start to evaluate new drugs in the space in the future, as we know that underlying principle is so critical. So you mentioned that this drug is standard of practice if patients can tolerate it. Right. What are the types of patients where maybe this benefit may not be worth the risk?
Yeah, I think I would say that it's worth trying in the vast majority of cases. Like I mentioned, we've had a couple where you have microscopic disease left over, so probably not in them. But if they have measurable disease, I would certainly be a proponent of trying it across the board. The issues that we've run into, primarily some unusual, unexpected toxicities, I would say. Of course, this is a drug we've been using in the metastatic space for quite a long time. The main toxicity that we run into, the dose limiting toxicity in that group, tends to be thrombocytopenia. We've not necessarily seen that much in the adjuvant setting. What we've seen more so is some lack of appetite, some worsening of neuropathy. So that's been more so why we've had to discontinue it. And we really didn't expect it, because we have patients sail through in the metastatic setting that are heavily pretreated, have seen a number of drugs. But for some reason, when we've used this adjuvantly, we have had to switch patients back to trastuzumab, unfortunately, a few times because of those side effects.